Welcome, everyone. My name's Amber Rogers, and I work at Mountain Pacific Quality Health. Today, we're going to have a great presentation by Dr. Brett Bell and about chronic pain and assessing and treatment as well as tapering. This will be an ongoing series of addressing chronic pain in primary care medicine. And so we look forward to not only you joining us for this time, but also our subsequent lectures. Dr. Bell, I'll give a brief bio of her accomplishments. She is a board certified family physician with an additional year of training in addiction medicine. She attended University of Washington School of Medicine with a residency at Swedish Cherry Hill and the Seattle Indian Health Board. Some of Dr. Bell's interests in medicine include addiction medicine, reproductive health, obstetrics, native health, and pediatrics. She is also a faculty physician for the family medicine residency of Western Montana. So we would like to welcome Dr. Bell. Go take it away.
Great. So, thanks for that introduction, Amy. So kind of just a brief outline of the presentation. I'm going to talk a little bit about the epidemiology of opioid prescribing, also touch on some validated tools for assessing chronic pain, discuss some strategies for saying no gracefully and navigating difficult conversations with patients, review the CDC recommendations, and talk a little bit about the diagnosis of opioid use disorder and talk about some principles for a successful opioid taper. As far as learning objectives, hopefully by the end of the session, you'll be able to understand some appropriate use of some validated screening tools for chronic pain and monitoring tools, make sense of conflicting and confusing recommendations from the CDC, and review opioid tapers and principles of a successful taper. In terms of disclosures, I have no financial relationships to disclose. I do have to disclose that I am not a pain specialist. So this presentation will be primarily from a primary care perspective, although I do have some additional training in addiction medicine. And I'll let Amber present the Mountain Quality Pacific Health disclosures.
Yes, so this project is sponsored by both a HRSA grant as well as our contract with CMS. So we do not have any outside business disclosures to discuss. Next.
Great.
So when you registered for this webinar, we asked you a couple polling questions because we always like to get a perspective from the audience about where they're coming from. And so the first question was, how often do you currently assess substance use disorder screening? And you can see that 33% of the people that answered said no, that they didn't do that. There is a large percent of NA or unknown, and that's because several of the people that are attending today are not in a clinic setting. And so they're coming from a different perspective. And only 29% said yes, that they always screen, and 9% said, well, sometimes we screen. So I think we have some work to do in this category. Next slide. We also asked what the major concerns about prescribing opioids was, and this one greatly totals over 100% because you could select more than one category. But you can see that between efficacy and concerns about misuse were the highest rating as far as the number of people that were concerned. Tapering also was an important issue for several of our audience members. So that just kind of sets the stage for where the audience is. And I forgot to mention that we have just a couple of housekeeping things to go over. Number one, yes, you will receive a recording and the slides for those that were registered but were unable to attend. And We will also at that same time send you out our next educational offering. Feel free to write any questions or comments in chat. We welcome your learning experiences, what kind of troubles you might be having, or just comments about the presentation. We take all of that into account. And with no further ado, I will turn it back over to Dr. Bell.
Great, thank you so much. So I just wanted to review some of the epidemiology. I do have a master's in public health, so I can't let you escape without some epidemiology in the presentation. So these graphs are from the Centers for Disease Control and Prevention. And on the left-hand side of your screen, these are morphine equivalents per capita by county in the United States. With the dark black being the highest number of morphine equivalents per capita and the lighter blue being fewer morphine equivalents per capita. And this is in 2015. And then the graph on the right shows changes over time. As you can see, it's pretty variable across the United States. There has been, as you can see, a pretty substantial reduction in the number of morphine equivalents per capita over this time period, but there are some places where the number of morphine equivalents are increasing or where they're not changing. So this also comes from the CDC and shows some changes over time, shows kind of a mixed picture as well. The interesting trends show a slight increase or a slight decrease in the amount of daily morphine equivalents that are prescribed, but it seems like people tend to be prescribing longer duration of prescriptions and dispensing more days supply at a time, which may reflect more sort of chronicity of chronic pain treatment. And then I just really want to highlight concurrent prescription. So this comes from a neat study in JAMA that looked at overdose deaths that are attributed to prescription medications in the United States. And it's a little older from 2010, but I still think it's valuable to talk about. So this is based on National Vital Statistics System death certificate data. And among overdose deaths involving opioid analgesics, the pharmaceuticals most often involved in those deaths were benzodiazepines. About 30% of deaths also involved benzodiazepines, antidepressants, about 13%, anti-epileptic and anti-Parkinsonism drugs, about 6.8%, and then antipsychotics involving about 4.7%. So what this tells us is that when we're prescribing medications for chronic pain, prescribing opioids, we really need to pay particular attention to those concurrent prescriptions and pay particular attention to those benzodiazepine prescriptions. And I think the other thing I really want to highlight is that it looks like about 50% of you had some serious doubts about the efficacy of opioids for chronic pain, and I think that's a well-founded doubt. So this is a pretty groundbreaking study that came out in JAMA in 2018. It basically looked at patients with osteoarthritis from hip, knee, or back pain. They were all primary care patients at the VA in Minneapolis, and they were randomized to three-step medication regimens, either an opioid three-step medication regimen or a non-opioid medication regimen. And the primary outcome that they measured was the brief pain inventory scores. And the neat thing about this study is, one, that the exclusion criteria were very few. So patients the only reason patients were excluded were for life expectancy less than 12 months, if they were already on opioids, or if they had contraindications to the non-opioid medications. And so it's a fairly broad swath of patients. And the findings were really interesting. So the opioid, and they also used an intent to treat analysis, which is always what we look for in a randomized trial. So the opioid group had more symptoms over the course of the trial. There was no difference detected in deaths or other adverse outcomes, although it was only followed for a 12-month period. And there was no significant difference in pain-related function between the two groups over the 12 months. And actually, pain intensity was significantly better in the non-opioid group. So what I take away from this is that I think sometimes our fears about whether opioids are going to be or whether non-opioids are going to be as effective as opioids for chronic pain. I think based on this study, we can say that it's not necessarily the case that opioids are going to be more effective, and that they may have, as we know, all of the adverse consequences of opioids. It may not be worth the risk. So how do we say no to patients? So I thought this was a really neat schematic that I think can be really helpful for providers. This comes from a article called Getting to Know How to Respond to Inappropriate Patient Requests from Family Practice Management. And it really goes through kind of identifying your own feelings when you're in the situation with the patient, thinking about exactly why you want to say no to the request, and then really trying to give the patient the benefit of the doubt and see them in the best possible light. Patients don't always know that a request might be inappropriate, and then really explicitly and clearly state that you were saying no, and that complying with their request would be poor medical care. So, for example, continuing to prescribe opioids for an acute complaint in somebody, or continuing to prescribe a high-dose benzodiazepine, all those sorts of things. And then reestablish rapport by kind of showing all those empathetic skills that we all work so hard with patients. And I think just being cautious, of course, not to talk too much during the conversation, because oftentimes when the physician talks too much, that has been shown to sort of lengthen the duration of the conversation and tends to make things more difficult. So when I'm saying no to patients, I'll often channel my mom of a 3-year-old voice, and in my most empathetic tone, say no, and really empathize hard with the patient's feelings and disappointment. Before prescribing opioids, I think it's really advisable to use a validated screening tool to screen for potential problems. So this is the SOAPR, the Screen and Opioid Assessment for Patients with Pain. And this is a valuable tool, and I wasn't able to put the whole tool on the slide, but it's a very valuable tool for assessing, how high of a risk is it to start opioids for chronic pain in this patient, and what kind of issues or problems might we anticipate. So turning now to the CDC recommendations, and these recommendations came out in 2016. It's a set of 12 recommendations for the management of chronic pain. I'm not going to go into great detail about these because I believe there are some lectures later in the series from some of our pharmacy colleagues about the sort of nitty-gritty details of the CDC recommendations. But I do want to highlight that some of these recommendations ended up being, I think, a little bit over-interpreted. So they ended up causing some confusion, leading patients to be abruptly discontinued off of opioids or tapered inappropriately. And an unintended consequence of that has been that some patients who have maybe previously been on prescribed opioids for chronic pain, then go on to develop an opioid use disorder from illicit opioids. And so I think it's important to highlight some of the the challenges with those recommendations and talk about the clarifications that came out in 2019. So before I talk about those clarifications, I saw maybe that there was a question or two in the chat box. Is that right?
Nope, that's just me encouraging people to chat in the chat box. So anybody, yeah, just feel free to use the chat box as you think of things, and then we will highlight and take various breaks during the presentation to answer those questions as we're on the topic. So feel free to be liberal with the chat.
Perfect. So in 2019, the CDC came out with kind of a clarification or revision of their recommendations around chronic pain. And the gist of these recommendations is really that if patients are doing well with no aberrant sort of behaviors around pain, medications, no dose escalations, no sort of red flag type behaviors like early refills, losing prescriptions, etc., that it's reasonable to continue their opioids, but to continually revisit the risks and benefits. And we'll talk about a schema a little bit later in the presentation for how to revisit those risks and benefits with patients and how to talk about that with patients. The other thing that I think they clarified was that it's really important to be extremely cautious when starting patients on opioids for chronic pain, so as not to sort of continue and perpetuate the expectation that chronic pain management means opioids no matter what. And I think using tools like the SOPR to screen for potential folks who might struggle with abusing prescription opioids can be really helpful, as well as sort of reviewing some of the data around the effectiveness of opioids for chronic pain and reminding patients that it may actually not be the most effective treatment. In the last year, I had the experience of inheriting a number of patients from various other providers who were managing chronic pain with opioids, and it has been very challenging to set limits with patients and to continually revisit those risks and benefits. And I think the following things have been helpful for me, and we'll talk about some recommendations from the Oregon Pain Guidance website a little bit later, but taking any opportunity that you can to revisit their pain management and opioid regimen, reviewing the risks of long-term opioid therapy at the first visit can be very helpful, and then taking a hard line on the combination of opioids plus a benzodiazepine and really emphasizing the dangers of that combination for patients. And oftentimes I've found it helpful to offer patients the choice. You know, we can continue managing your chronic pain with your opioid, or we can continue managing your chronic anxiety with a benzodiazepine, but it's not safe for me to do both. And then taking the time to explain our clinic policies, giving patients advance notice that we're going to keep revisiting their dose, especially if they're nearing an age milestone such as turning 65 or their health status changes in some way, and then continuing to press for multimodal pain control and non-pharmacological interventions. The other thing I lean on heavily is my clinic is lucky enough to have a medication safety committee, which is made up of medical, pharmacy, and nursing staff, and reviews cases where patients may have high morphine equivalents or concerning medication combinations, and having them review cases can be extraordinarily helpful. The other really important thing is to be continually assessing the patient's chronic pain. So this means continually revisiting how effective your treatment regimen is for the patient. So I really like the PEG-3, the pain screening tool, which is sort of an abbreviated version of the brief pain inventory, but is just much faster for patients to fill out. The point here isn't that the PEG is superior to any other sort of chronic pain monitoring tool. The point here is that you pick a pain assessment tool and continue to use it to revisit the effectiveness of the regimen over time, just as we do in primary care with screening with the PHQ-9 or the GAD-7 for monitoring depression and anxiety. So I promised you some chronic pain kind of assessment schemas and a framework for discussing chronic pain with patients. And I really want to highlight the Oregon Pain Guidance website put out by the state of Oregon, which has really tremendous and helpful details about how to assess chronic pain with patients, how to have difficult conversations. And I really like this algorithm for assessing the chronic pain regimen. So you're doing a systemic assessment of risks and benefits of continuing the opioid use at the current dose. You know, if it seems like for the patient, the benefits are outweighing the risks, that's great, continue, and then make a plan to reassess at least quarterly with the patient when you're seeing them for that Q3-month visit. If it seems like the risks are outweighing the benefits, then it's time to talk about that with the patient. So consider starting a taper with the patient. And if the patient is really struggling with the taper, that's when you need to sort of assess them for an opioid use disorder. So and this can get very, very tricky with chronic pain versus opioid use disorder. And they make a lot of this distinction between prescription opioid dependence and opioid use disorder. And I'll talk a little bit about the diagnosis of opioid use disorder. So the addiction behaviors checklist, I think, can be a really helpful guideline for kind of assessing, are some of these behaviors present? Is this someone where I need to think more about does this patient have an opioid use disorder? And some of the checklist items correspond really nicely with the DSM-5 opioid use disorder criteria, but I think this can be really helpful because it's targeted at prescribed opioid analgesics. So if a patient if you are suspicious that a patient has an opioid use disorder, I think reviewing the addiction behavior checklist, reviewing the diagnosis of opioid use disorder in the DSM-5. And I realize that the DSM-5 criteria for substance use disorders can feel kind of large and cumbersome, but they all really boil down to one really fundamental question, which is how much are opioids ruining this person's life? The question that we're trying to answer here is how much is this person's life impacted by opioids, and are the medications that we're prescribing causing more harm than benefit to this person? And I think that's the really helpful question to keep in mind. So I want to highlight another mnemonic for discussing opioid prescriptions with patients and discussing a taper and discussing challenges, problems and challenges with an opioid prescription with the patient. So this again comes from the fabulous Oregon Pain Guidance website. And it basically goes through a checklist for how to discuss these issues with patients. So you definitely want to set, if you can, take extra time with the patient and use all of those helpful motivational interviewing skills. And then, consider tapering if the patient is over 90 morphine equivalents, if they're on concurrent benzodiazepines, if they have co-occurring conditions that set them up for higher risk of opioid overdose, such as respiratory problems like COPD, asthma, obstructive sleep apnea, if they're experiencing adverse effects. And then I think also normalizing and explaining that there's that physical dependence is certainly something that happens to people, no matter what their intention is with these medications. If anyone is prescribed an opioid for more than 2 weeks, they will become physically dependent. That's just a physiological fact. And then when you do decide to taper, there are some principles that I'll highlight a little bit greater detail in the next slide. And then I think also emphasizing other strategies for coping with pain. So helping patients to understand a little bit about how pain works, helping patients to understand how past traumas and adverse childhood experiences can affect their experience of pain, promoting sleep, promoting healthy activities, social connections, good nutritional choices, and consider non-opioid pain medications. So in terms of taper principles, I think these are some really important basic principles for tapers. So going slowly. When the CDC came out with those guidelines in 2016, I think many patients went through extremely rapid tapers, which can be very uncomfortable for patients and can be very distressing. And so, the recommendation is really dose reductions of 5 to 20% per month. And keep in mind also that folks may need to go much slower in the taper at the very end compared to the beginning. Another really important principle is it's okay to hold a taper, meaning to not step down that particular month, to not decrease the dose that particular month, but it's never okay to go backwards on a taper. The plan is always, we're going to keep reducing your dose until either you're off of the medication or you're at a safer dose that I'm more comfortable prescribing. But we're not going to go backwards. And I think emphasizing that with the patient at the beginning. And then I think also giving the patient autonomy, giving the patient the choice, would you like to decrease the dose, or would you like to decrease the frequency this month? And that can give patients some measure of control when they often feel sort of like this is completely out of their control. And then reassuring the patient, walking alongside them, which is what we do in primary care, that you'll be with them the whole way. You'll continue to help them with their pain and advocate for them, but you will be tapering the medication. And then also being realistic with the patient that things may be uncomfortable and things may get worse before they get better. So I just want to leave with a few really important resources. Again, I borrowed heavily from some materials put out by the Oregon Pain Guidance website, which is really a treasure trove of resources for managing, monitoring, and tapering chronic pain medications. So I can't recommend it enough. It has a really compassionate but strong limit setting type approach, which I think is what's needed with patients who are struggling with chronic pain medications. And then I also want to highlight that the importance of being able to offer treatment for patients who do develop an opioid use disorder. So I'm an addiction medicine specialist in addition to being a primary care doctor, and I really believe so strongly that that every primary care physician and maybe even every physician should have their buprenorphine waiver. The PCSS Now, which is the website for buprenorphine prescribing done by the American Academy of Psychiatry, is now offering free online buprenorphine waiver training for physicians and nurse practitioners and PAs. And so it's a really phenomenal resource, and I recommend that everyone who can get their waiver to prescribe and be familiar with how to treat opioid use disorder if patients do develop it. And lastly, I want to highlight this really incredible work of a pain researcher who's comes from a doctor of physical therapy background, who's an Australian pain researcher. His name is Lorimer Mosley, and this is a really excellent lecture from him about sort of the threat detection system and the relationship between pain and trauma. And I think it's fairly accessible for patients. He also has some shorter TED Talks, but I think anyone who's managing chronic pain patients should be familiar with his work, and it's a lot of pain neuroscience, but a little bit more digestible for the average person, the average patient. So I want to just highlight those resources, and I'll turn it back over to Amber.
Okay, thanks for that. So what I'd like everybody to do is put any questions that you might have either in the chat box, or you can raise your hand and we can promote you to speak as well. We would love to hear what are some of your pain points to talk about chronic pain and pain points, but I have a question for Dr. Bell.
Yeah.
I know that you have a fairly robust care team at your disposal. What is a way that you have routinely involved your care team? Is it in, assessing, their fill rates with the pharmacy, or what other tips do you have to lessen the provider workload and include other team members?
Yeah, absolutely. So I think nobody does it alone. And so I would say I really try to utilize the entire available team that we have at Partnership Health Center in Missoula. So in terms of our pharmacy colleagues, I think they help a lot with some of the sort of checking and monitoring of patients. Because I'm new at Partnership, they've been helpful as far as filling in about which patients they might be concerned about. And then I think utilizing our behavioral health team. So we actually have a chronic pain sort of education and support group at our clinic that has been really phenomenal. And I think patients who participated in it have gotten a lot out of it. And one of our clinical psychologists runs the chronic pain support group, and they teach all sorts of techniques for management of kind of the psychological aspects of pain management. And then, utilizing, of course, our nursing and MA teams to kind of help with some of the clerical pieces. Of course, in addition to my own double checking that I'm doing with the prescription drug registry and all of those sorts of things. So,
well, that was going to be my next question, was about the prescription drug monitoring program. But let's flip, and not to make it all about me. Let's answer Brenda Thomas's question. She has a question of, is buprenorphine a better substitute for chronic pain, or is it just for the opioid use disorder?
Yeah, that's a really great question. So there are 2 FDA approved indications for buprenorphine. One is chronic pain, and one is treating opioid use disorder. And I think pharmacologically, I think buprenorphine is really well suited to treating chronic pain, and I've seen some really phenomenal responses in patients who have chronic pain that are treated with buprenorphine. I believe it's only the buprenorphine patch, and then another buprenorphine buccal film that are FDA approved for treatment of chronic pain. And because buprenorphine is this partial agonist activity, it seems to have less sort of dependence, less fatigue, less mental fogginess compared to full agonist opioids. And I think it's a much safer alternative for patients with chronic pain. That said, it is quite potent, and I don't think it's appropriate for every single patient with chronic pain. For patients who are on less than 30 morphine equivalents per day, the recommendation is to not start them on a buprenorphine patch. So I think it gets tricky. For that subset of patients who have chronic pain and opioid use disorder, I think buprenorphine is a very clearly superior choice to methadone in that sense, because I do think that people seem to get better benefit from buprenorphine. There's also this interesting effect So the mu opioid receptor is not the only opioid receptor. There is this kappa opioid receptor, which seems to be responsible for a lot of the dysphoria associated with opioid use. And the buprenorphine is actually an antagonist for that kappa receptor. So what I've heard patients say who were previously on full agonist opioids and are now managed with buprenorphine is that they finally feel clear, they finally feel like they can think normally compared to being on opioids for chronic pain. So I think for select patients, it's a really great choice. I don't think I would make a blanket statement and say that buprenorphine is superior to full agonist opioids for all patients with chronic pain.
And then we have another question from Kyla. Can you briefly address the altered pathophysiologic and pharmacologic changes that occur in patients on long-term opioids, opioid-induced hyperalgesia, and how to explain this to patients?
Yeah, that's a great question. So in terms of physiologic changes, so as I think I mentioned earlier in the talk, after about 2 weeks of being on daily opioids, almost every person will develop a physical tolerance and dependence to opioids. So if you were to abruptly discontinue opioids after 2 weeks in any person who'd been on them consistently, they would experience withdrawal symptoms. And that just has to do with sort of the upregulation and the number of mu opioid receptors and the presence of the mu opioid receptor in all sorts of areas of the body. In terms of the opioid hyperalgesia phenomenon, I guess that would be another reason to consider buprenorphine for patients who have chronic pain, because for whatever reason, the buprenorphine partial agonist activity does seem to play a role in interrupting opioid hyperalgesia. So for patients who have hyperalgesia, I think buprenorphine can be a great choice for chronic pain management. In terms of how to explain it to patients, I would say, I think the patients who are experiencing opioid hyperalgesia, they get it pretty much right away. I think what I tell people is, what we have observed through large studies is that over time, there are a subset of patients who develop worsening and worsening pain in response to being on opioids, and explain that there's this phenomenon called opioid hyperalgesia where it seems to get worse and worse over time. And the patients who are experiencing it will really, their eyes will kind of light up and they'll kind of get it right away. I think for the patients that maybe aren't experiencing it, it's a harder conversation to sort of work that into the list of risks of opioids. But I do discuss it. I do discuss that there's a phenomenon of opioids worsening pain over time.
Awesome. Feel free to go ahead and chat any other questions in the chat box. Also, I just want to highlight a couple of things that are going to be ongoing in our series. We'll have some conversation, and our next webinar is going to be about stigma and what is some stigmatizing language that you and your team can look out for. We're also going to talk about, if you do not have a medication-assisted treatment program in your clinic, we're going to talk about the return on investment of starting one and how you go about that process for those of you that don't have that. And we are also going to have some of our pharmacy team talk about the CDC prescribing guidelines. Some of the things that we're very interested in helping our clinics with is things like, how do you incorporate checking the prescription drug monitoring program prior to prescribing. So you have some of those difficult conversations up front rather than after they've already received a prescription from you. And how do you address those team dynamics to decrease the provider workload where it's possible? So we are very interested in learning what you all need to best improve the care of your patients. So feel free to chat in any of those types of comments of specific things that you are looking for as we start this journey of addressing our not only our individual 4 states, but our whole society's reliance on opioids and taking maybe what may be considered a quick fix, and it turns into a very long haul for several of us. So would love to know your thoughts on that. Any other questions from anyone? I'll give you a second. Okay, let's go ahead to the next slide, and you can still chat in anything that you wish. In all of our webinars, we really like to end with a leaving in action. It's one thing to attend a webinar and then promptly forget about it the next day. But what we really want you to do is commit to some sort of action on this topic of addressing chronic pain. So, you know, if you all could just type in one action step that you would like to do, it can be as simple as, I'm going to figure out how to register for the prescription drug monitoring program in my state. Or it can be as complex as, I'm going to formulate a team to talk about how we can do medication review as a clinic, and talk and copy a little bit about what Dr. Bell was talking about with their medication safety committee. Any and all of those types of commitment steps we celebrate. So would love to hear about what you're doing. And then just take a moment to not only commit to that in your head, but also to write it down and send a quick email to people. What can you do? What kinds of data points can you point to in your organization so that you can tell when you make a difference? Second of all, we would love for you to review the education needs of your clinic. What are some questions that your providers have? What are some maybe patient relationship skill building that your team needs to improve on? If you could write those down and just make a list of those, we have a specific thing called a change log, which is super helpful to track those great ideas that come up from a team planning. And I will link to those in a little blog that will come out after this event. So you don't have to worry about trying to search for those. We'll send those to you. And then thirdly, once you get a team identified, you know, start something. Just try one thing. It's very important to make sure that we're not harming our patients. I love that slide about how much are opioids ruining this person's life, instead of just taking the easy way out. Sometimes it takes a lot longer to have a broader conversation with patients. And lastly, if other of you that are listening to this, if you've had clinic successes or hospital successes, we would love to also highlight your practice and figure out what you have done and how others can learn from your team, and even from as broad a perspective as an entire community. When we all row the boat together, we usually get there faster. And so it's super important to make sure we're bringing along our entire team, our entire organization, and our community. With that, any other questions or comments? And again, feel free to chat things in. I'll give you just a minute. And If there's nothing else, Dr. Bell, do you have any other final thoughts?
No, I don't have any final thoughts except just compassionate limit setting is the name of the game with chronic opioid management. So
I like that, compassionate limit setting. That is a great note to end on. Okay, thank you all for attending, and we look for you to sign up for our additional education events that are going to be happening over the next year. So take care, and everybody, please mask up. Thank you. Oh, wait, if you're still there. Oh, awesome, Melissa. I got my first commitment to action. Thank you very much. I love people that listen to directions. You get the gold star for the day. Happy to leave the chat box open, but otherwise we will go ahead and close this event. And thank you very much, Dr. Bell. It was a pleasure.
thank you.
Okay, bye-bye.